Welcome to another deep dive.
Great to be here.
Today we're plunging into a topic well, it's been making significant waves. It touches on public health, medical ethics, and really the nature of trust in scientific guidance.
Absolutely. A really critical intersection.
Our source material for this deep dive is particularly interesting. It's excerpts from a recent piece in JAMA.
The Journal of the American Medical Association.
Right, titled Professional Responsibility for COVID-19 Vaccination in Pregnancy. And this article, it offers a pretty critical view on a major, and as we'll discuss, quite abrupt policy shift regarding vaccine recommendations. So our mission today is really to unpack this. What exactly happened? Why do the authors of this piece think it's so significant?
And what it means for patients.
Exactly, what it might mean for you, the patient, and maybe for the future of healthcare too. It feels like a vital conversation.
Indeed, I think this deep dive is crucial. It helps us understand how official health guidance gets formed.
And sometimes unformed.
Yes, and sometimes abruptly reformed. And what that means for, clinicians and patients trying to navigate these really critical health decisions. It's definitely more than just one policy change. It digs into the principles behind medical practice.
Okay, so let's start right there with the event that actually triggered this whole discussion. Can you kind of set the scene for us? What happened?
Absolutely. So May 27th, 2025.
Yeah.
A major announcement comes out from the Department of Health and Human Services Secretary, Robert F. Kennedy, Jr.
Okay.
And he stated quite clearly, the quote was, "The COVID vaccine for healthy children and healthy pregnant women has been removed from the CDC recommended immunization schedule." Just like that.
Wow. Okay. Removed. So how did the CDC, the Centers for Disease Control and Prevention, how did they respond or, adjust their own guidance after that?
Well, the CDC updated its guidance pretty quickly afterwards. They removed their COVID-19 vaccine recommendations specifically for children under 18 and for pregnant women.
So they aligned with the announcement.
They did, but their new advice, it shifted. For children, it became shared decision-making.
Okay.
And for pregnant women, the advice was now, talk to your healthcare provider about which vaccines are right for you. A much softer stance.
Right. A very different framing. Now, here's where, as you said, the JAMA authors come in. They immediately flagged this as an abrupt policy reversal. Why was their reaction so strong, so immediate? What were they worried about right off the bat?
Well, their main concern, the one they stated up front, was that this decision was made without transparent scientific deliberation. That lack of process worried them.
Okay, transparency.
Yes. And they immediately warned of immediate and serious consequences for maternal and neonatal health. That was the big one.
Consequences.
Right. But beyond that, they also argued it would undermine public trust in evidence-based medicine, potentially reduce vaccine uptake generally, and maybe even limit access if insurance coverage changed. It felt like a sudden shift with potentially wide ripples.
That's a really potent list of concerns. Yet, despite this reversal from HHS and the CDC's change, many professional medical organizations, they didn't follow suit, did they? They held their ground.
They absolutely did, and this is crucial. 32 organizations, including really big names like the American College of Obstetricians and Gynecologists, ACOG,
Right?
and the American Medical Association, the AMA, they unequivocally reaffirmed their strong endorsement of COVID-19 vaccination for pregnant and lactating individuals.
32 organizations.
Yes. And it wasn't just, a quiet note. It felt like a real pushback, a reaffirmation of their commitment to patient safety and the scientific evidence, directly countering the new federal guidance.
That's a very clear, very united front from the medical community. It really raises the question, why? Why such a strong, almost immediate reaction from so many respected groups? What was the fundamental disagreement here?
Well, their strong reaction really comes down to what the JAMA authors describe as a troubling conflation of evidence-based medicine with preference-sensitive care.
Okay, that sounds like the core of it.
It really is. It's the heart of their ethical argument. And understanding that distinction is, I think, critical to grasping why they found this policy shift so problematic.
Shared decision-making. I mean, it sounds good, doesn't it? Empowering. But the authors are saying it's being misused here. Can you unpack that distinction for us? Evidence-based versus preference-sensitive.
Yeah, it's a key point. So shared decision-making, or SDM, it sounds great, very patient-centered, but ethically, it's really only appropriate when something called clinical equipoise exists.
Clinical equipoise. Okay, what's that?
Think of it as a state where, scientifically speaking, there isn't one clearly superior option. It means there are, two or more reasonable options. that carry pretty comparable risk-benefit profiles.
So multiple good paths.
Exactly. And in those specific situations, patient preferences, their values, their circumstances, they rightfully guide the choice. That's where SDM shines.
Okay, that makes sense. So to make it really concrete, can you give us some examples from obstetrics where shared decision-making is the right approach, where that equipoise exists?
Absolutely. The source article gives some good ones, like deciding on the mode of delivery after you've had a prior cesarean, a VBAC versus a repeat C-section.
Right.
Or maybe the timing of delivery in late term, but otherwise low-risk pregnancies. Or choosing between different options for pain relief during labor, like an epidural or other methods.
Gotcha. Areas with genuine trade-offs and personal factors.
Precisely. These are places where different reasonable choices exist, and the decision really should be driven by the individual situation and what matters most to them.
But, and here's the pivot, the authors argue that applying that same SDM approach to COVID-19 vaccination and pregnancy is, well, fundamentally flawed. Why?
Because, they argue, the situation isn't one of equipoise. They state that when high-quality evidence clearly supports one course of action, which they believe is true for COVID vaccination and pregnancy, then failing to make a strong recommendation under the guise of neutrality represents a dereliction of professional duty.
A dereliction of duty, strong words.
Very strong. They explicitly say COVID-19 vaccination and pregnancy does not meet criteria for clinical equipoise because, in their view, the evidence just isn't balanced. It points clearly in one direction.
Okay, so let's talk about that evidence. What exactly is the evidence supporting vaccination and pregnancy that makes it so clear-cut for these authors?
They emphasize that the scientific literature consistently demonstrates that COVID-19 vaccination is effective and its benefits significantly outweigh risks.
Such as?
Well, robust evidence showing reduced maternal risk of getting severely ill, ending up in the ICU, or even dying from COVID.
Which were serious risks in pregnancy.
Absolutely. And beyond the mother, vaccination also decreases the risk of preterm birth, which is a major concern. Plus, it provides protective antibodies to the newborn through the placenta and breast milk.
Right, that passive immunity we talked about.
Exactly. And critically, they note the vaccines have been extensively studied in pregnant women and have shown consistently excellent safety profiles. So, effectiveness and safety.
So faced with this strong evidence, the authors don't just critique, they propose a solution, right? This framework called the professional responsibility model. What is that, and why is it so relevant right now?
Yeah, think of this model as like an ethical toolkit for doctors, especially when things get confusing, maybe due to outside pressures like politics. It's designed to provide essential ethical guidance when political forces create confusion in medical practice.
An ethical compass.
Kind of, yeah. It tries to balance two core duties: promoting the patient's welfare, that's beneficence, and respecting their autonomy, their right to choose.
Okay, balancing act.
But crucially, this model says clinicians must offer explicit recommendations when strong evidence favors specific interventions. They shouldn't just step back and be neutral if the evidence isn't neutral. They call that abandoning patients through false neutrality.
Okay, so it demands a recommendation based on evidence.
Yeah.
How does this model specifically guide clinicians then when they're talking to pregnant patients about the COVID-19 vaccine?
It's pretty direct. It requires clinicians to provide an evidence-based recommendation for vaccination.
Not just options, a recommendation.
A recommendation. It says they should actively recommend the COVID-19 vaccine to all pregnant patients, anyone planning pregnancy, and those breastfeeding, basically as soon as they're eligible.
And how should they explain it?
They should clearly explain the risks of not getting vaccinated, the increased danger from COVID infection during pregnancy, like severe illness, ICU stays, preterm birth, while also emphasizing the strong safety record of the vaccines themselves. Give the full picture.
Okay, but what about vaccine hesitancy? That's a real thing, a common challenge. How does this model help clinicians navigate those often very sensitive conversations?
That's a really important piece. The model fully acknowledges that clinicians have an ethical and legal duty to address hesitancy and what's called informed refusal.
Informed refusal.
Right. So if a patient is reluctant, the clinician should respectfully ask why, understand their specific concerns, then provide clear, accurate information about the risks of not vaccinating risks to both the patient and the fetus. And then, importantly, document that whole conversation and maybe revisit the topic later at future appointments. And this is key, always always maintain respect for the patient's final decision, their autonomy.
Hmm.
It's about informing, not forcing.
And the authors even provide some actual phrases clinicians could use that sounds incredibly helpful for these tough talks.
They do, which is very practical. They suggest things like, I want to understand your concerns and ensure you have complete information about the risks of remaining unvaccinated during pregnancy so we can work together to keep you and your baby healthy. Kind of collaborative.
Yeah, partnership language.
Exactly. And to make sure the respect for autonomy is clear, they suggest saying something like, I will answer all your questions so you can make a decision based on accurate information and your values, and I respect whatever decision you make.
So it really emphasizes that the goal is a truly informed choice, grounded in solid information, not just any choice.
Precisely. The authors frame this model as representing appropriate informed consent with moral clarity, ethics, and professional integrity. And they explicitly contrast that with what they see as shared decision-making masquerading as neutrality.
Which brings us back to the consequences. What happens when, in the author's view, shared decision-making is misapplied like this false neutrality? What are the actual impacts clinically, professionally, societally?
Well, clinically, they argue the results are quite serious. When vaccination is framed as just a preference, not strongly recommended based on evidence, vaccine uptake tends to go down.
That makes sense.
And that decrease can potentially increase morbidity and mortality further, hitting hardest in populations already facing health disparities.
They've got gaps.
Potentially, yes. They also argue this false neutrality can inadvertently give legitimacy to vaccine hesitancy, maybe even increase hesitancy among doctors themselves, which could ultimately contribute to worse outcomes, like higher maternal mortality, especially among those already vulnerable.
Wow. Are there any immediate sort of real-world examples of this impact being felt already? Is it theoretical or happening now?
According to the article, it's already happening. They state the immediate real-world impact is already evident. They point to reports coming in of pharmacies refusing to provide COVID-19 vaccines to pregnant women.
Really? Refusing?
Yes, and healthcare workers reporting significant confusion about what the actual clinical guidance is now. So, confusion and access issues cropping up almost immediately.
Okay, that's tangible. And what about the broader impacts? Professionally, for medicine, and societally?
Professionally, the concern is that it undermines medical expertise precisely when patients need this guidance the most. When they rely on clinicians to make sense of complex data.
Eroding the expert role.
In a way, yes. And it sets what they call a dangerous precedent for potentially misclassifying other evidence-based treatments down the line. Societally, this is especially worrying in our current climate of, well, widespread medical misinformation. They even reference Kennedy's advice to do your own research. When official health bodies seem to legitimize this kind of neutrality over clear evidence, it undermines the foundational trust patients place in medical expertise.
That trust issue again.
It's central.
Right.
And there's also a worry about spillover effects. Could this uncertainty impact uptake of other crucial vaccines too?
Right, a potential ripple effect beyond just COVID vaccines. So, wrapping this up, it feels like this deep dive really underscores just how high the stakes are when it comes to clear, evidence-based medical recommendations, especially for vulnerable groups like pregnant women and their babies.
Absolutely. The author's conclusion is powerful. They state flatly that neutrality is not ethical when strong evidence points one way. Instead, they call it a failure of professional responsibility.
A failure.
Yes. They describe the CDC's shift, under the circumstances, as professional abandonment. And they argue very strongly that their professional responsibility model offers the clear ethical path forward.
So the call to action essentially is for correction, a return to clear, evidence-based guidance. This whole discussion really highlights how vital it is to understand not just what the medical guidance says, but how it gets made.
The process behind it.
Exactly. And the ethical frameworks or lack thereof that underpin it, and the very real consequences when those frameworks are, at least in the view of these authors, disregarded.
And maybe connecting this to the bigger picture, it leaves us with a really important question for you, the listener, to think about. If we see more policy shifts like this, how might that impact the long-term relationship between patients and their doctors, their healthcare providers, and what does it do to the overall public trust in science and scientific institutions?
That is definitely something to ponder. Thanks so much for joining us on this deep dive today.
My pleasure.
We really hope this exploration has given you a clearer, more informed perspective on what is truly a vital issue.